as you know, in ICU, a lot of hectic things can go on. And these can have grave consequences on patients' physical and cognitive function, as you heard Jonathan talk about in the previous lecture. This is a slide that shows that the physical function at discharge can have long-term survival effect. And as the physical function decreases in your survivors, the long-term mortality increases in these patients. And we did a similar analysis with our study, with our patients that go through our ICU. And in this group A, who were alert and mobile, group B were alert, but who were confined to bed at discharge of hospital. And then the group C was patients who were not alert and was confined to bed. As you can see from the survival graph, the people who had a decreased mental and physical ability had the poorest prognosis. And also this study from NEJM 2013 shows that ICU survivors who were very well before they were admitted to ICU had long-term cognitive impairments, with a 34% having a cognitive impairment similar to moderate TBI, and 24% compatible with mild Alzheimer's disease, especially in the patient group who were over 65. So what can we do to increase physical and cognitive function in these patients? And one of the things that we can do is having early mobilization and occupational therapy in these patients. And these concepts are integrated into an ABCDEF bundle that Wes Eli and others talked about in this conference. And also, it's in the PADIS guideline that was recently developed by the SCCM in 2018. This is our center, the Samsung Medical Center. It's in the heart of Gangnam area in Seoul. But we know that early physical therapy and occupational therapy can help the patients. But in resource-limited countries like, I can't say, maybe we are better than some other countries in the region, but we are also not as, resources that we have are not as plentiful as some in the Western countries. For example, this is a table showing our ICU that I work in, and one that Johns Hopkins Hospital has in their ICU. We have only one dedicated faculty at certain time, but they have a lot. Nurse-to-patient ratio, which is the best in Korea. Our center is the best in Korea. One nurse takes care of 2 patients. That's the lowest nurse-to-patient ratio. But in Johns Hopkins Medical ICU, they have 1 patient for 1 nurse. Also, we don't have any respiratory therapists that helps us. And no, we did not have any dedicated therapists that helped us, while they have 6 physical therapists, occupational therapists, and 1 speech language therapist that helps us. But we had a chance to reorganize how we took care of patients in 2012, where our president at the time really wanted to renovate how we did how we did clinical work, and he helped us to organize how we delivered critical care also. So in 2013, we were the first center in Korea have a separate department for critical care medicine, and we organized our care into a center for intensive care. And in this center for intensive care, I really focused on 2 areas. One was the ECMO team, which result I presented yesterday. And also, we tried to organize an early mobilization team to deliver optimal care with the resources that we had to our patients. So first and best thing that I did was to hire someone who is passionate and who was willing to do this hard work, and this is Dr. Zhang, who was very instrumental in setting up our ICU mobilization program. So our ICU mobilization team, we started in 2013, and we tried to have a comprehensive multidisciplinary approach with an intensivist and the fellows that were rounding in our ICU, and also the residents really helped us. And it was very difficult to get buy-in from the nurse because they were already doing so much that they thought it would be more dangerous for the patient if they knew that early mobilization worked because of the evidence that we showed them, but they were really concerned because they didn't have that much manpower. But in the end, we succeeded in having her come over to our side. Then we have some respiratory specialist nurses that helps us, and in the later phase, starting from 2014, the rehabilitation department gave us half day of support, and also clinical pharmacist had a big role in our team. And this is our team, and this is me, and this is Dr. Chung, and he's a nurse manager, and these are the nurses. And he's a physical therapist and clinical pharmacologist. An initial stage of our program, it was rather haphazard. So it was intensivist-driven mobilization. We were enthusiastic, but not that well organized. So in the later phase of 2013 and starting in 2014, the rehab department gave us some manpower support, and then we got to organize the physiotherapy component of our rehabilitation program. Also, I sent people over to Johns Hopkins to stay there for one week, and she's a nurse, pharmacist, Dr. Zhang, and she's a respiratory therapist nurse, and they stayed there, and they really learned a lot from their team, and I thank Dr. Needham and their team for giving us this support. So we have a similar program to other programs, stepwise approach, and teamwork here is the key. As you can see, the unit manager, nurse, physiotherapist, and a nurse assistant all taking care of this patient. So in the preparatory phase of our program, we had to optimize analgesia and sedation. This is the key because you cannot mobilize someone who is RAS negative 3 or 4. This is the art and first step in every program, I think. And we try to monitor and manage delirium in the optimal way and provide a stabilized environment for the patient and get the family involved, use ICU Diary, improve sleep and quantity of sleep. So this is the sedation protocol that we developed, and we had to educate everyone involved, the nurses, the residents, and the pharmacists about this protocol, and we got them to follow this protocol. And we set up a brochure for the family about our rehabilitation program and how it works, and set up an ICU diary for the patient. And also to have the patient well rested for the next day, we made sure that during the night we tried to get him to sleep as much as possible. And we developed a track where they would follow when they were mobilized. And with safety screening sheet that we use. And we meet every morning to discuss who to mobilize, because we only have half day of support. Most of the passive things are done by the bedside nurses, and the physiotherapists, when they come, we focus on people who need higher mobilization things. So we would walk, say, sitting and things, plan our activity for the day. And we start with passive range of motion, then active range of motion, and resistance exercise, where sometimes we use the bedside bicycle. Here, the patient is doing his resistance exercise, which will increase strength, cardiovascular condition, endurance. And sometimes we don't use it that much, but we sometimes try to use electromuscular stimulation to stimulate the muscles. And when he's ready for that, we move on to sitting, then to standing. And when he stands, then we get him to support without standing, while the nurses, they look at his vital signs. And airway protection is key when you are mobilizing people with an artificial airway. Then if you can balance, now stepping is the next step. Then if he's ready, we also try to march the patient as much as possible. And we have a criteria for stopping the exercise. It's a similar criteria that's recommended by the early mobilization guideline. And also, we also can mobilize people on ECMO if they can be they can be sedated so that they are very calm and rested, and we try to mobilize as much as possible. And here we have a patient who was on VV ECMO, and we got him to stand. Then here he's standing, and a little bit later he will start working. So it's a big work for our team, because you see here, you can see at least 5 people looking after this patient at this time. And we trying to get him to go outside of the ICU, but here, that's the door. Yeah. And so to get the skeptical people to buy into your way of thinking, you need to create early success stories. So we use the early mobilization board, where we would post pictures of our patients doing early mobilization. Then this is a Hall of Fame when people would go to a higher mobilization. We would post their pictures so that the family and the nurses and people involved would know that we were succeeding in having this patient mobilized. And also we did the quality improvement project, and we won the contest in 2015. And we published some papers on safety of our early mobilization in papers. And this also created a sense of achievement among our team. And this is a paper that we published in 2015, our first 520 physiotherapy treatment sessions about the safety concerns. And as you can see, the event rate for 1,000 physiotherapy treatment treatment sessions were respiratory distress around 20, desaturation 11, tachypnea, bradycardia about 8, patient intolerance about 8, and we had only 1 tracheostomy tube removal during our sessions. And most of the sessions, even though they had some derangement of physiologic derangement, it was not life-threatening. Also, this is a paper that we published about the early mobilization of patients on CRRT. And we show that even patients on CRRT can be mobilized quite safely. And this is a paper on early mobilization of patients in ECMO. And we also show that it's relatively safe if you do it carefully to mobilize a patient on ECMO. To maintain this program, we have a monthly review of our ABCDEF metrics. So the use of sedation, the status of the patients, delirium trends, and ICU PT report are discussed among our team so that we can maintain and improve our program. This is the proportion of sedated patients. This is month, and you can see there's a little bit of a variation, but you can see that most of the patients are very lightly sedated in our patients. And CAM ICU errors, through our feedback, now the CAM ICU assessment by our bedside nurses are very stable, and we have a very good nurses to do that. And the delirium that's assessed by CAM ICU is decreasing. There is a decreasing trend in delirium assessed by our CAM ICU. And then our pediatric counterpart in our hospital are now trying to do pediatric early mobilization, and they've been doing it for 2 years. And it's a very catchy phrase. They call it Do-Re-Mi rehabilitation. So Do means that a patient cannot move independently. So it's passive range of motion. Re is active assistance. It's a range of motion with active assistance. And Mi is high level mobility. And this catchy phrase really reflects the pediatric population, I think. And in our surgical ICUs, where most of the patients are post-op patients who were relatively well before they were in for surgery, we have a nurse-driven ICU rehabilitation program, and they are doing walking and early mobilization in these patients, and they are doing quite well. But to expand our early mobilization in Korea, I think we need to better educate our colleagues and get more people involved, the doctors, nurses, the rehabilitation doctors, physiotherapists, and also there's a need for standardizing our practices. And most importantly, to get it really take off, we need to persuade our government to reimburse for ICU rehabilitation, because I alluded yesterday that our medical insurance system is very peculiar in that most of the hospitals are independently and privately owned, but the only insurance company is the government. And if the government doesn't have a category for ICU rehabilitation, it will not reimburse. So the hospitals don't have any economic incentive to give us the manpower or the instrument to do early mobilization. So it's very difficult to really take this to a higher level in a countrywide sense. So these are the barriers that perceived by the ICU nurses on rehabilitation. That was published in, it's in press, it was recently published. You can see that the inappropriate number of patient ratio, lack of time, high workload of the nurses, they perceive it as a real barrier for rehabilitation. And this is a survey done in our physiotherapists. And many of the physiotherapists don't even have heard of MRC score, which is a method to assess ICU weakness. Also, they perceive that staffing and lack of program and education is a barrier to propagation of ICU rehabilitation. So to spread the news out and get early mobilization to more patients, we have created a society, which I'm the first president, and we are having annual meetings since 2017, and this was the first meeting of our group. And also we had a second annual Asian Pacific Early Mobilization Conference in Seoul in 2016. In summary, through dedication and teamwork and help of many people, we were able to establish first ICU rehabilitation program in South Korea. It has spread a little bit to other hospitals, and close to 10 centers are doing early mobilization in Korea. But to really have this take off, we need to educate our colleagues on the benefits of early mobilization, and efforts to have it reimbursed by our insurance system, I think, is essential. Thank you for listening.